afternoon. Why don't we get started? I am tremendously honored to, first I gotta put on my reading glasses, introduce Dr. Michael Granovetter as of this summer. We've worked with Dr. Granovetter for a couple of years, first through his work with Marlene Berman's Vision Lab is when we kind of started working with Michael. I think we wrote to the American Epilepsy Society and said, you have to fund this grant for him because he is so awesome. And then he got his MD this summer, and now he's a resident at NYU, and he's very dedicated to understanding vision in our kids postoperatively, and he's also really done a deep dive on the data in our patient registry. So some of you know we have a patient registry that's powered by parents, that's powered by you, where you get to jump in and share your child's story in a data-driven way that we then share with the research community and get published. And that's one of the things that Michael does in collaboration with us, so he's going to share what we've learned from the registry so far. Welcome, Michael.
Thank you, Monica. Hi, everybody. As Monica said, I'm Michael. Today, I'm really excited to be able to share some of the initial results from the Pediatric Epilepsy Surgery Alliance's Global Pediatric Epilepsy Surgery Registry. That's a mouthful. Importantly, I want to be able to recognize everybody in this room who has already helped to contribute to this registry and moving the needle forward on this very important area of research. And hopefully we can encourage some other folks to get involved in the registry by the end of this as well. Before I talk about data in the registry itself, I want to set a little bit of the context for the purpose of the registry. So the focus of the talk today is going to be on hemispheric epilepsy surgery. So that can be an anatomical hemispherectomy, a functional hemispherectomy, hemispherotomy, hemidecortication, et cetera. Basically either complete or near complete removal or disconnection of an entire hemisphere, because that represents the majority of the population of folks who come to these meetings and who have participated in the registry. And we know that hemispheric epilepsy surgery is a really effective treatment for seizures. So this is just one of many, many studies where you can see on the y-axis here, this is the percent of people who are seizure-free after so many years. And you can see initially close to 75% plus of patients who get hemispheric epilepsy surgery are seizure-free in the first couple of years. And even 10 years out, 50% of folks can actually remain completely seizure-free from hemispheric epilepsy surgery. But over time, we've been studying a lot about the effects of these surgeries on seizure burden, but there are so many things that we don't understand about functional day-to-day outcomes. What are the costs of removing an entire hemisphere? So I'm not going to give an entire brain anatomy lecture today, but we know that different parts of the brain are involved in things like vision, hearing, speech, language, cognition, et cetera. And so you can imagine if you take an entire brain and then you remove 50% of it, there's a question of to what extent can that remaining hemisphere actually take on the burden of what would normally require two hemispheres? And this is actually some of the questions that inspired a lot of the work that I've done in my PhD dissertation and since then with the help of the Pediatric Epilepsy Surgery Alliance. So I just wanted to highlight one of those studies here that we published a couple of years ago from data collected at the 2019 Cleveland meeting. And what we were interested in that particular case is we had 24 folks from the Pediatric Epilepsy Surgery Alliance who had a complete removal of their left hemisphere, and then we had some other folks who had a complete removal of their right hemisphere. And we wanted to test one particular function that is actually normally relegated to either the left hemisphere or the right hemisphere, and that is face and word recognition. So traditionally, language and word recognition is relegated to the left hemisphere by adulthood. For those of you who need mnemonics like myself, I always try to remind myself language and left both start with L. And face recognition is a process that normally emerges in the right hemisphere. And we wanted to see if you have surgery really early on, can one hemisphere actually take on the work that usually requires two hemispheres? Can one hemisphere actually do both face and word recognition? And what we found in that study is that you can see here on the y-axis is the accuracy on tasks of face and word recognition. And in blue, I'm showing data from healthy kids who have never had epilepsy or hemispheric surgeries. And in red, I'm showing data from patients who either had a left hemispherectomy or a right hemispherectomy. And you can see that on average, if you have a whole hemisphere removed, you do a little bit worse at things like word and face recognition. But overall, you actually perform pretty well. At about 85% accuracy on average at both tasks, suggesting that 50% loss of brain does not equate to 50% loss of function. And so this was one example of a study that really highlighted for us some of the resilience of the developing brain and almost promises that plasticity could confer positive functional outcomes. But that being said, this is just one particular function, and there's still so much that we don't know. And so a couple of years ago, myself and Monica Jones also attended a gathering of folks at the National Institutes of Health where there was a question of what should researchers be studying in the years to come in terms of epilepsy research, epilepsy surgery research, et cetera. And one of the outcomes from that meeting was that there is a greater need to be studying non-seizure outcomes. Non-seizure outcomes of epilepsy and epilepsy treatments. And those include things such as neurodevelopment, mental health, cognition, and health-related quality of life. This had never before been in the NIH's mission for epilepsy research benchmarks. And the Pediatric Epilepsy Surgery Alliance has really helped to take up that mantle to try to better understand and study these functional outcomes that we still don't quite know. And so to date, the Alliance has a registry that has 171 patients who have had a full hemispheric surgery. And of that group, it's a pretty equal split of folks who have had surgery on the left side and folks who have had surgery on the right side. And I just want to highlight a couple of important pieces of information about this sample. I hope everybody really likes histograms and bar graphs because we're going to be looking at a bunch of those over the next 15 minutes or so. So this one right here, I know it's a little bit hard to read with the projector, so I'll try to summarize what these graphs are saying. But here what I'm showing is the count of the number of people in our sample, and I'm showing the distribution of when they initially were diagnosed as having seizures. And on average, the median or average of our sample shows that most of the participants in the registry started having seizures before 1 year of life. Some were actually even prenatal. That's why the range says -1 to 18 years of life. But the vast majority before 1 year. So we're talking about very early epilepsy, hemispheric epilepsy surgeries. And the etiology of these the etiology of the seizures really quite varied. But I will highlight that the most common diagnoses that we see in kids who are undergoing hemispheric epilepsy surgery are things like cortical dysplasia, hemimegalencephaly, and stroke. But you can see that there's also still a wide range of others, and many of the participants in the registry actually have more than one of these different etiologies. And importantly, folks don't necessarily go to a single surgery. So while the majority of children who had hemispheric epilepsy surgery in our particular sample had one surgery, Many others needed 2, 3, and you can see in a couple of cases 4 surgeries, sometimes to complete a full hemispherectomy or a full hemispherotomy, and in other cases, repeats of the hemispherectomy procedure. And on average, the age at first surgery was about 2 years of age, but again, in the sample, it's a fairly wide range. I think the oldest child in our sample had a surgery at 17, but most under the age of 10. And the age at last surgery is a little bit later, about 4 years of age on average, with, again, a range throughout the course of childhood. And importantly, in the particular data sample that we're going to be looking at today, the parents of the children who we sent out the survey to, the children had an average age of about 11. So even though these are children who, on average, initially had seizures starting at year less than 1 of life and had surgery completed usually on average by age of 4, what we're going to be looking at here are functional outcomes later in life, later in development, on average at age 11. And just to demonstrate what we already know from prior literature, in this particular sample, the majority of the participants are seizure-free post-surgery. And I want to highlight the format of the bar plots I'm going to be showing for the next several slides. I'm always going to be showing pre-surgical percentages in blue and post-surgical percentages in red. So anything that's red is after surgery. And anything in blue is before surgery. And you can see on the bottom, I have the percentage of participants in each of the different categories. And you can see close to 80% after surgery do not have any seizures that families are aware of. And you can see before surgery in blue that many parents were reporting that their children were having seizures several times per day and several times per hour. And that's really important to think about in the context of functional outcomes, because while the focus here is going to be on functional outcomes and not necessarily seizure outcomes, the two are very interrelated. You can imagine if your child is having seizures several times per hour, which is close to 40% of the sample, that is going to have an impact on their day-to-day function. So it's really remarkable to see, again, that improvement in seizure burden after surgery. And also that you see that the number of medications that children are taking after their surgeries really goes down. The mantra right now in the field is that if you fail 2 anti-epileptic medications, that necessitates a referral for a potential surgical workup. And on average, after surgery, most children are only on 1 anti-epileptic. But I should note here that you can see that a good amount of our sample actually is off anti-epileptics. So they're not only seizure-free, but they're not taking seizure medications. That's also important to think about in the context of functional outcomes, because many seizure medications also come with their own side effects, and those side effects can also affect day-to-day function. So with all that being said, there are many questions that need to be addressed with regard to how does hemispheric surgery affect functional outcomes? And there are so many different domains, but the domains that the registry focuses on in particular are the following. Those include vision, hearing, motor, and endocrine function. And then we're going to go through each of these different domains, but then at the end, I'm going to highlight cognition, because cognition, you can imagine, is a much broader domain, and we've done a much deeper dive on some of those analyses from the registry. But to start off talking about visual outcomes after hemispheric surgery, I know this is a little bit hard to read with the projector, so I will try to read this out as best as I can. But again, we have here percentages of participants who had each of the following visual diagnoses pre and post-surgery. Pre-surgery, again, being in blue, post-surgery in red. And you can see quite clearly up at the top that the absolute most common visual diagnosis after a hemispheric surgery is a homonymous hemianopsia. And in this plot, it actually says that 80% of children have homonymous hemianopia after their epilepsy surgery. But this is a parent-reported registry, and it's important to note that, and it's something that we're going to circle back to at the end of the talk, that sometimes a lot of these diagnoses aren't made either right away or even in the follow-up period. So if a child is potentially not referred to an optometrist or an ophthalmologist, or if it's not something that a neurologist knows to think about and to counsel parents about, a parent might not even realize that their child has a hemianopia. But what we know from the literature is that hemianopia occurs in close to all children after hemispheric epilepsy surgery. And just to clarify what a hemianopia is, it's a visual field cut. So it is when a child cannot see half of their visual world. It's not a loss of vision in a single eye. It's not a loss of peripheral vision. If a child has a hemispherectomy to one side of their brain, they cannot see half of their visual field. They need to, throughout their development, readjust their gaze to try to take in as much information from their visual world as possible. And this can actually be a quite significant deficit for some children, and it's really important for us to be able to make families aware of this particular diagnosis. Now, I'll highlight that the rest of the diagnoses, strabismus is an eye movement diagnosis, usually related to the hemianopia when a child is trying to readjust their gaze because they can't see half of their visual world. And also one of the most prevalent post-op visual diagnoses is cortical visual impairment, which essentially is a visual impairment that's not related to damage to the eye, it's related to damage to the brain. And all of these children have had half of their brain resected or disconnected. So all of these children technically qualify for cortical visual impairment, but as you can see here, only about 25 to 30% of families are actually counseled about this particular diagnosis and are aware that their child has cortical visual impairment, or what you might hear abbreviated CVI. So moving on to auditory diagnoses, I want to highlight here that only 25%, so it's not the majority of individuals, but 25% of individuals who have had hemispheric surgery after the surgery have what's called a central auditory processing impairment. Similar to what I was just saying on the previous slide about a cortical visual impairment, which is a visual impairment because you're missing the part of the brain involved in vision, central auditory processing impairment is having trouble processing things that you can hear using your brain. So it's not that these children can't hear sounds, they can't hear noises, they can't hear speech. It's that the centers in the brain that are responsible for processing that information are impaired, in part because half of the auditory system is removed. And only about 25% of families report this diagnosis, but actually if you don't ask families about the diagnoses themselves, and if instead you ask about auditory symptoms, you actually see much higher percentages of families reporting that their children find themselves overwhelmed in loud environments, that they're overly sensitive to certain sounds, that they're unable to pay attention to conversations in noisy rooms. All symptoms that we would expect in a central auditory processing disorder. And a lot of families might not necessarily know the name of that, nor may they be being referred to an audiologist or therapist who may be able to help address some of these symptoms that they're reporting with quite high percentages. Moving on to the motor system, as many folks might be familiar with, after a hemispheric surgery, if you are missing half of your brain, you are going to be losing your motor function on the opposite side of your body. And close to 80% of our sample report this. It's called hemiplegia hemiparesis, and it's the most widely diagnosed outcome after hemispheric epilepsy surgery, that with the anonymous hemianopia. And you'll notice too that a lot of these children have hemiplegia, or impairment in movement on one side of the body, even before surgery, in blue. So again, that's something also to take into account when we're thinking about functional outcomes after surgery. Function before surgery is also important. Sometimes, because of the pathology in the brain, they've already lost a lot of their motor function on one side. And so it's not the surgery itself that is producing a motor deficit, even though it might produce a little bit more of a motor deficit than before surgery, but some of that deficit exists in the preoperative period. And then again, when you ask parents about the effects on postoperative motor symptoms, a majority will say that their children need assistance to sit, to stand, and to walk. But I also want to highlight that even though 80% have this hemiplegia, a good percentage of those who have the diagnosis of hemiplegia are able to still sit unassisted, stand unassisted, walk unassisted. And part of that is due to some of the therapies that those children are receiving in the postoperative period. I want to wrap up my discussion on different functional outcomes with the effects on post-op endocrine diagnoses. Here again, you can see that there's no slam dunk endocrine diagnosis that the majority of children who undergo hemispheric epilepsy surgery have. The most prevalent endocrine diagnosis is early precocious puberty, so that's puberty before the expected age that you would expect your child to begin puberty, and that's in about 15 to 20% of the sample, again, primarily in the postoperative period. But that being said, 5 to 10% of families are still reporting a variety of other endocrine diagnoses. For instance, problems with the thyroid gland, problems with growth hormone, et cetera. And so even though this isn't something that we see in the vast majority of patients, it's something that families and, more importantly, physicians on the team need to be aware about in the postoperative period. And this projector is making the font here a little bit small, but I'll just say that a lot of the symptoms that are associated with endocrine diagnoses are quite prevalent in the postoperative period. The endocrine system is involved in regulating your body's temperature. It's involved in regulating your desire to eat, to drink. It's involved in regulating how often you may need to urinate, et cetera. And all of these things are functional outcomes that parents are reporting, even if they're not necessarily reporting a specific endocrine diagnosis. And all of these symptoms are symptoms that should warrant an endocrinology workup with an endocrinologist. So I want to now get into a little bit of the weeds of postoperative cognitive diagnoses. You can see here that there is a wide range of cognitive outcomes that can occur both before a hemispheric epilepsy surgery, because epilepsy itself can affect cognition, but also following epilepsy surgery. We see that there is a very high prevalence of what's called aphasia, an inability to produce language or to understand language, and a significantly high rate of intellectual impairment and specific learning disability, as well as dysgraphia, problems with reading and writing, attention deficit disorder, and autism spectrum disorder. These are all things that families and clinicians should be aware of, both in the preoperative period because of their relation to epilepsy, but also in the postoperative period. When we ran analyses on this, we show that in the postoperative period, the rate of these different diagnoses goes up. Now, like before, in addition to asking families about different postoperative diagnoses, it's also important to ask families about what they see in their child in terms of their global cognitive outcome. Because at the end of the day, our goal is not to be trying to aim for a certain IQ score or to aim for a certain set of diagnoses. It's to aim to the point where families feel comfortable with the cognitive outcome after the surgery. So this again is a Guardian reported cognition rating on a 5-point scale. And you can see that there's quite a range, that some families are reporting that their child has significant cognitive impairment in the postoperative period. Some are reporting even above average cognitive outcomes in the post-op period, but the majority are indicating at least mild to moderate to significant impairment after surgery. And a question that we get in epilepsy surgery clinic all the time is, can cognitive outcome actually be predicted from things like age at seizure onset, age at surgery, or even the side of the brain that you're resecting, the left or the right? And it's the common wisdom that because the younger brain is quote unquote more plastic, it's more resilient, that perhaps if you have surgery at an earlier age, you might have a better long-term cognitive outcome. Or perhaps if your seizures started at an earlier age, you might have a better long-term cognitive outcome. But this is a little difficult to see here because of the projector, but I'll just say that we looked at folks who reported average, mild cognitive impairment, moderate cognitive impairment, and significant cognitive impairment, and tried to do an analysis to correlate that with the age at which seizures started, and we found no relationship in that data. So age of seizure onset did not necessarily predict long-term cognitive outcome. Same thing with the age at the most recent surgery. So even children who received surgery earlier versus those who received it later, that had no impact on this global cognitive outcome score that we asked families. And lastly, if you break it down here by whether a child had a left hemisphere resected, which is shown here in blue, or a right hemisphere resected, shown here in orange, you can't tease apart any differences in what that's going to look like in terms of cognitive outcomes in the post-op period. The only variable that actually seemed to suggest could be useful for predicting cognitive outcome in the post-op period is etiology of why a child had seizures in the first place. So some of the most common etiologies that we discussed were hemimegalencephaly, stroke, and cortical dysplasia. And when you actually plot out these data and you analyze these data, here I'm showing children who had a cortical dysplasia diagnosis in blue, hemimegalencephaly in orange, and stroke in purple. You can see that the kids who had stroke as their initial diagnosis are more on the right side of this plot. They're more likely to have a mild to average cognition rating in the post-op period. But those children who have cortical dysplasia in blue are more likely to have a moderate impairment in the post-op period. And our initial analyses don't show necessarily an effect on hemimegalencephaly, on the different cognition ratings post-op. And I'll just add too that select cognitive outcomes may also be affected by the site of surgery. So as I mentioned earlier in this talk, language is typically developed on the left side of the brain. And so it should be no surprise that if you have a left-sided surgery, again, left-sided is shown here on this plot in blue, right-sided in orange. If you have a left-sided surgery, you're more likely to have aphasia or a speech production or speech understanding impairment after surgery compared to children who have a right hemisphere surgery. Interestingly, in our data, we also saw that if your child has a left hemispheric surgery, they're also more likely to have attention deficit disorder than a right hemispheric surgery. Again, this is preliminary data on a relatively small sample, but this also suggests to us that when the left hemisphere of the brain is removed, the part of the brain that's very important for language, the right hemisphere has a lot of work to do to catch up. And so one of our, while we don't have evidence yet to support any particular hypothesis or idea, one idea that has been circulated is the idea that because the right hemisphere has to now learn language and has to learn other functions that are typically ascribed to the left hemisphere, that perhaps that affects other executive functions like attention deficit disorder. But we're hoping to do a little bit more research to address that. And I want to say that I want to get to an important part of this talk, which is, are patients following up with those providers who can address these particular cognitive comorbidities. I said that a lot of children in the post-op period are having difficulties with language production, language understanding, with autism, with attention. And what I'm showing here are different providers who participants in our sample followed with post-operatively. And I'll just say at the outset that there were more providers in nearly every specialty in the post-surgical period versus the pre-surgical period, suggesting that a lot of these providers didn't really get involved until post-op. But here we're seeing the post-op providers. And you can see that many children are appropriately following with their occupational therapist, their physical therapist, their pediatrician, their speech therapist to address a lot of the diagnoses that we discussed, such as aphasia, such as the weakness to the body on one side. But something that was quite sobering from these data is fewer than a quarter of the participants in the sample, despite the significant cognitive comorbidities that we see, are actually following up with behavioral and psychological health services. And these data really suggest to us that we have many individuals who are having many postoperative cognitive diagnoses, but they're not following up with the behavioral and psychological specialists that they most likely need. And so this is an area that the healthcare system that is being underutilized for these patients. That being said, the more cognitive comorbidities that a child has, the more providers that are necessary on their team. So since I'm running low on time, I wanted to end with a couple of other important pieces of data from the registry. And one is that the future feels uncertain for a lot of families, and we don't even need to show the data on these slides for a lot of folks in this room to understand that. But it is something that we ask on the registry. And we ask, can you see your child down the road independently living on their own? And a lot of families note that it's still too early for them to tell. Similarly, we ask if they can see their child employed down the road. And a large percentage of families, again, say that it's still too early to tell. And one of the reasons for this is because we need more data on functional outcomes after hemispheric epilepsy surgery. When you are initially in that visit deciding to get the epilepsy surgery, or in those postoperative visits in the months to years afterwards, there's still a lot of open questions. And part of that is because we're still in the process of gathering some of these functional outcome data. It's one of the reasons why the work of this registry is so important, so that down the road, hopefully we can provide a little bit more certainty for families in the future if we can know a little bit more about the functional outcomes of children who have already undergone this procedure. But to end on a little message of hope is that despite everything, every plot that I showed in this talk, taking everything into consideration, and don't forget at the beginning we talked about how many children were having multiple seizures per hour. We're on sometimes 3, 4, 5, in some cases 10 medications that they trialed before surgery. Taking everything into account, the vast majority of families report improved quality of life for their child after hemispheric epilepsy surgery. So the burden is on us as researchers and clinicians now to translate that into how can we improve the quality of life further? How can we provide clear answers for every patient, for every family, in terms of what they can expect in terms of the specifics of functional outcomes for their kids? And so just to highlight some takeaways, the majority of hemispheric surgery patients are seizure-free based on the data from our sample and from previous research. Our sample shows that these individuals have improved quality of life after surgery, but nonetheless, there are impairments that we should be aware of. And when I say we, again, I'm talking about the clinicians, the researchers as well, because it's important for us to be able to provide the appropriate counseling and make sure that families are following up with the right providers. And it's also important to acknowledge that outcomes vary. And for cognition, perhaps etiology inside of resection may associate and help us better predict outcomes, that behavioral health resources are underutilized. Oh. Okay, there wasn't another point there. And I just wanted to say, already because of people in this room and others who have helped to contribute to this registry, we are now doing the work of trying to inform general pediatricians, neurologists, neurosurgeons, specialists in different fields about these functional outcomes, so that we can't go to the field and say, we need to be surveying these different symptoms without the data to support it, which is why this registry is so important. And this work has already been shared at an endocrinology meeting. It's been published in one of the premier epilepsy journals, and has been presented at Child Neurology Society, American Epilepsy Society, et cetera. And we have a couple of manuscripts currently in preparation. And our hope here really is that by spreading the word about these functional outcomes, then when the next family has to sit through a discussion with their care team, that care team is well informed to give the appropriate information to families about what specialists they need to see, what should they anticipate in the postoperative period, et cetera. So how can you help? Please sign up for the registry if you haven't already. Our sample is 171, which is one of the highest in the literature. But many scientists expect more. The goal of the registry is to eventually reach 1,000 participants, and to do that, we're going to need everybody's help. So with that, I just want to wrap up and acknowledge a couple of people. In particular, Monica Jones I could acknowledge her for like an hour, but I want to leave time for questions. So for everything that she's done for the Epilepsy Surgery Alliance, for being the principal investigator on this registry, for Kladji Puka, who is one of the statisticians who has worked on this registry, and some of these specific cognitive outcomes. I've been doing some fine-tune analyses with my former PhD advisor, Dr. Marlene Berman, as well as Sophia Robert at Carnegie Mellon. Ethan Klein has been helping myself and Dr. Puka with some of the broader outcome analyses that I showed in this talk, and Dr. Patterson, who is the one of the pediatric epileptologists, the head of the epilepsy program at Children's Hospital of Pittsburgh, has also contributed a lot to some of the analyses I presented in this talk. And with that, special thank you to all the participating families. Please reach out to me via email if you have any questions about this work, and I'm excited to hopefully take some questions. Thank you. Dr. Abel. Although, yeah.
I have a big voice, so I'll take 185.
Okay.
You know how I said the registry is your voice? I'll just yell. It's your voice. I'd like to point out who's listening to your voice right now. You have Dr. Skellig Stone, who's a neurosurgeon at Boston Children's, Dr. Taylor Abel, who's the chief of pediatric neurosurgery at UPMC, Dr. George Ibrahim from Sick Kids Toronto, Dr. Arya Falla, the clinical director of pediatric and adult epilepsy surgery at UCLA, just stepped out to take a phone call. So when I say the registry is your voice, they're actually listening to it. As well as other clinicians like neuropsychologists, vision researchers, et cetera. So, and who can't wait for Michael to finish his residency and become a neurologist? I can't wait. I can't wait. So awesome. Dr. Abel, you had a question.
I can speak really loud. First of all, congratulations. That was a great talk. It was very informative, and you really did a wonderful job. The question I had is about the slide where you talk about time of the onset of epilepsy, age, and frequency as predictors of outcome. And I was wondering if you used duration of epilepsy as a predictor of outcome, because there's a lot of debate in the field of epilepsy surgery about whether or not we can be doing surgery as early as possible to improve outcomes. And so I was wondering if you, A, have looked at duration, and then if that didn't show anything, maybe you could consider some kind of combined predictor like we use quality adjusted life years to measure quality of life after certain treatments. Maybe you could consider something like an epilepsy severity adjusted life year and see if that predicts outcome. What do you think?
I 100% agree. And in fact, you're not the first person to ask this question. It's been asked before when I've presented this data many times. One of the issues that I think you alluded to is kind of this issue of when you're trying to look at the delta of age of seizure onset to age at first surgery. There's the issue of the other like cofactors in that analysis. So the age at which in particular, I think the biggest issue is, okay, so let me back up. So the biggest issue is sometimes folks aren't referred to epilepsy surgery soon enough. So sometimes we're looking in the data set and a child may have been failing 7, 8, 9 medications. And the problem is their neurologist didn't refer them after failing 2. And some families are in big academic medical centers and they get referred right away. At Children's National, they're now trying to refer kids after 1 medication. So a big issue there is teasing out what is actually a delay in surgical referral to actually the actual epileptic pathology occurring over time. We have some other variables in the registry that we're trying to use to build kind of that score that you're suggesting, but it's still a little bit preliminary, but it's something that we're looking at.
But that's like almost the reason why we want to answer this question, because that means if there really is an association there, then we need to make sure people get referred earlier.
Yep, definitely agree. Or
What are we doing about getting that referral sooner? Because that's we had seizures before 1, we didn't have surgery until 6.5, because we were not referred because we were in a small town.
We're trying as a patient advocacy organization to get the word out. We have a poorly used website at stopthedelay.org where we share all the research that talks about that. When I go to medical meetings, we talk about the delay of surgery as being a problem. Candidly, it's a problem of a lot of the neurologists, and I'm not embarrassed to tell them that that's their issue. We provide up to $1,000 of travel funds to families who need funding, can't afford to get to an evaluation, more than 50 miles from home. But I'll be honest with you, it's still a problem out there. And it's a problem in the clinical community. It's not with families, it's the doctors that wait way too long to refer, way too long. Yeah, I feel your pain for sure, for sure.
You have to call, let them know which one. Here, this is going into the video, not over the speakers, but.
Okay, perfect. So I was just surprised I forgot. I have seen those or some of those data before and then I forgot. But so if I understand properly, is 100% of our families should have said yes for homonymous hemianopia and 100% should have said yes to CAPD. But today, our families, when they get to surgery, don't know that their kids will all have, if you have a hemispherectomy, you will have homonymous hemianopia and CAPD. So I know that we're educating our families, but there's a clear need also for the medical community to inform before surgery.
I completely agree, and I want to clarify too that as somebody who trained in a vision research lab with Dr. Marlene Berman, one of our colleagues, Dr. Tina Liu, who is now a professor at Georgetown, like even did extensive functional MRI analyses in these patients. So put patients in the MRI, really looked like, can we see any remapping of anything in occipital cortex to suggest that there's a reorganization? We're really not seeing it. So that's why one of the pieces of evidence why we do feel confident that it's pretty close to 100%. And I agree, it is on this community. And so our hope is that with this initial registry data that we hope to get out into the world soon, that will be targeted toward epileptologists and neurologists so that they're aware about counseling about this in the both pre and post-operative periods. But that also our hope is one of the things that the Pediatric Epilepsy Surgery Alliance did as an organization yesterday is it gathered a number of us to discuss the idea of putting out a potential position paper to highlight for not even just neurologists, but potentially the entire kind of pediatric field. You know, here's kind of a checklist of things that a clinician, even a general practitioner who might be in a small town not near a major academic medical center should be aware of when counseling families. And one of the top things on that checklist needs to be hemianopia.
Michael, hi. It was a great talk. You've really done wonderful work with the registry. I'm impressed by Dr. Abel's question, which seems extremely urgent and, you know, really needs to be answered. And I have some ideas about how to address that question using some different kinds of statistical analyses. So perhaps you and Monica and I and Dr. Abel can also together, I think there are some interesting ways in which we can attempt to tackle a complex question like that one. Thanks.
I saw your hand go up first.
Hi, I just wanted to mention, and I can't imagine we're the only one in the room, but they talk about hemianopia and they talk about endocrine. GI never comes up, and I can tell you my son has had a GI problem as a comorbidity since the day he was born, along with seizures, and I was wondering if we could add that to the registry.
Thanks, a lot of great information. You know, but I'm wondering, with a registry like this, anytime you fill it out, it's kind of a snapshot in time. But as parents, we keep learning and, you know, understanding things that our children were experiencing but maybe didn't know how to articulate. Is there a living sense to the registry that you can go back and update as you learn more?
Yes, so what I'm presenting today is kind of the snapshot initial data, like what we call like the baseline, but there is in the process longitudinal data collection as well. The goal though is to try to build up our baseline and then really try to build from there. Because I'll just add, it's especially important, something that is I think a little bit can be undervalued or under-recognized is the importance of transition to adult care. And so following up with folks, I think the average in the sample was 11 years of age, but following up as they make that transition to adulthood, and even getting, this is parent-reported, but hopefully ultimately getting patient-reported outcomes as they become their own self-advocates is going to be really key.
Hi, I was wondering if you could go to the slide for the follow-up to address comorbidities.
Yes.
So I just, as a parent, I wanted to point out that sometimes we're lost to follow-up because we're triaging like our life, and there are like pretty much for all of us over 20 different providers that we're supposed to be following with, and I was wondering if there are any if there's a hope where you could have like a hemispherectomy clinic where like a family could come in and they'd have, you know, an agenda. It could even be multiple days where it's like, okay, you'll see the optometrist, you'll see the neurologist, the neurosurgeon, check in with all these other people. Is that something that is a possibility?
That would be my dream clinic
Yeah.
everywhere. I know Dr. Abel at Children's Hospital of Pittsburgh is currently trying to pilot a version of that clinic. And even then, that clinic, it's impossible to get all of those specialists into the room. I will say that one of the things that came up during our discussion yesterday about how do we survey these different symptoms in the post-op period is trying to be mindful of the fact that families are triaging, and to do so, you know, perhaps they don't need everything screened every single year. Maybe there are certain things that can be screened every 2 years or every 3 years, and you can stagger it in a way to make it more feasible for a family. But it's definitely something that we all, as a field, really hope to address. Agreed, and I'll just add, you know, it's one of the reasons that when we eventually try to get these results out and to try to get a position paper out on what we think is important to survey and screen, that'll be a resource for neurologists, but it's really going to be a resource for the neurologists to tell families to hand to their general pediatrician, who really should be coordinating all those aspects of care. I think we have to wrap up. I'm happy to take questions after. Thank you. Yeah, I'm happy to